got cancelled and the return flight also got cancelled. So I am missing this meeting in person, and we will have this excellent discussion and virtually. So can I start my slides? I hope someone will roll them for me.
Yes, sir. Yes, sir.
Yeah. So next slide. See, I have no conflict of interest to declare. I'm still trying to figure out how to become KOL. I was supposed to get some tips from Dr. Akhil, but unfortunately, I could not meet him in person, maybe in the next meeting. And I call myself as FOL. I'm a free opinion leader. And those who are active on Twitter and WhatsApp probably must have seen me giving a lot of free opinions on both these social media platforms. Next slide. So nowadays, there is a trend to omit surgery, if not the surgeons. I'm so happy that the other person who is doing this debate is a surgeon. I thought there will be two medical oncologists debating whether the surgery should be done or not. So I'm really happy that we are not totally omitting the surgeons. But we are trying to omit the surgery in early breast cancer, in small tumors, in a rectal cancer. There is a strong movement of wait and watch and not doing surgery. Then why not in metastatic RCC? So go to the next slide. Way back when I was resident in Tata Memorial Hospital, and we used to have heavy general OPD and very few residents. So I remember my senior, Dr. Nikhil, used to tell me that if the RCC patient comes without biopsy, send them to the surgery OPD. If the metastatic patient, they will operate, and they will, of course, it is a therapeutic as well as diagnostic, both. So that was the era when we have two papers published in early 2001, and they have shown that the cytoreductive nephrectomy has improved survival. But that was a very long back, and if you see on the right side, that the overall survival offered was short, around 11 to 17 months. So the times have changed. Next slide. Now, if you see, this is a very important slide, and if you see in the middle, there is a data about two trials called as Carmina and Certime, in which in the Carmina is a prospective trial in which they have compared sunitinib versus cytoreductive nephrectomy plus sunitinib, and of course there is a clear advantage of giving only sunitinib versus cytoreductive nephrectomy plus sunitinib. And in Certime, they try to distinguish again a prospective trial between initial nephrectomy versus delayed nephrectomy, and if you see that delayed nephrectomy arm has a significant improvement in the OS. These all figures are about the OS. So as my colleague has shown, that there is a lot of retrospective data because the evidence is less, but we have two prospective trials in which, at least with the use of TKI, they have shown that the nephrectomy upfront should be avoided, and maybe there is some discussion whether we can do a deferred nephrectomy or not. Now, next slide. Now, as it was shown that unfortunately in most of the immunotherapy trials, upfront nephrectomy was done because at the time of the accrual of those trials, probably the nephrectomy was considered as standard of care. But if you see those amongst all those trials, there is certain subset of patients in which the immunotherapy was given with the primary tumor in place. And there is a significant number of these patients. If you see, in most of these trials, almost 20 to 30% patients were treated in the absence of nephrectomy. And if you see the subgroup analysis for PFS and OS, most of them have a reasonably good hazard ratios of which is equivalent to the overall results. And hence, even though high-level evidence regarding nephrectomy is not available for ICI combinations, up to 30% of patients with primary were included in the majority of the immunotherapy combination trials, which is the current standard of care. Next slide. Now, so probably we are coming to this thought process that upfront nephrectomy should be deferred, but what about the deferred or delayed nephrectomy? And there is a thought process that those who got a very good response, probably CR, can we consider this? And if you see again the trials, almost around 10 to 15% patients get complete remission by giving only immunotherapy TKI combination. So why to subject them for upfront surgery when you're getting complete remission? And maybe in these subset of patients who get complete remission, one may think of doing a delayed nephrectomy. Next. Now, my colleague has shown a lot of papers published. So let me also show, this is a JAMA Oncology review, which has been published last month about immune checkpoint inhibitor therapy before nephrectomy for locally advanced and metastatic RCC review. Can I have the next slide? And they have very nicely shown a table in which they have shown the studies in which immunotherapy was given and the nephrectomy.
Sir, you are muted.
Am I audible? Sorry.
Yes, sir.
Yeah. So if you look at the second the study in which almost 113 patients were included, and I would like to look at the bottom of the table in which 90-day complications and 90-day readmission percentage, almost 11% patients in that study of 113 patients got significant grade 3, 4 complications, and there were readmissions required within the first 3 months. So surgery is not entirely free of side effects. Of course, it depends upon the high volume centers and the expertise of the surgeon and the expertise of the supportive care. But as a routine, if you're looking at India, you're routinely doing such surgeries. We should definitely think, especially in those patients who are getting the immunotherapy, immunimeters. Next slide, please. Now, if you look at their summary and very clearly understanding, despite level of evidence on the use of ICI in patients with metastatic RCC, indication and timing for nephrectomy in this setting is not clear. Data from retrospective studies confirm the feasibility of nephrectomy after ICI therapy, but the level of evidence is grade 3. Patients with favorable intermediate risk disease and acceptable performance status who respond well at metastatic site to the upfront ICI may benefit. This is the individual opinion of the author. But at the same time, the toxicity should be considered, and this should be done only in a high volume center where their expertise are available and a good surgical skill and a good supportive care is available, which need not be there in every part of our country. Next slide. And of course, there are upfront trials coming up, as shown by my colleague also. There is Nordic Sun trial. But if you see, the trial is not at all discussing about upfront nephrectomy. It is discussing only about the delayed nephrectomy in those patients who have got good response. So the randomization is clear cut on that upfront you give systemic therapy, and those who get response, maybe you can have a randomization. So that is about Nordic Sun. Next slide. And if again the next slide, the design about the probe trial is same, that there is no arm only of upfront nephrectomy. It is all about delayed nephrectomy. So the discussion of upfront nephrectomy is totally out in today's era. The discussion can be only about the delayed nephrectomy. And if you see the guidelines, next slide. So the EUA guidelines in March 2023 has very clearly said, in accordance to the Carmina and Certime data, the metastatic RCC patients and IMDC intermediate and poor risk patients with the primary tumor in place should be treated with upfront IO-based combination. And in patient with the clinical response to IO-based combination, subsequent CN may be considered. The same is with the ESMO 22 guidelines, that the secondary cytoreductive surgery in patients with local symptoms of the primary tumor or near complete response to stem therapy remains an option. So we are not excluding it, but definitely upfront cytoreductive surgery is not a standard of care in today's era. We can consider delayed nephrectomy in selected patients, those who have local symptoms, those because of the primary tumor, and that also in place where there is a high volume center with a good supportive care. So can I have my last concluding slide? And can I have the last slide, please? Next. So to do, not to do in nephrectomy, my answer is it should be a whole lot less than always. That you should not always do it. It should be definitely a whole lot less than always, but marginally more than never. So we are not totally excluding it, but we should make sure that it should not be a standard of care or a norm. It should be occasionally considered after a good multi-tumor board discussion, after weighing the pros and cons of the surgery associated side effects, especially in those patients who are responding well but still have local symptoms, not as a routine. Thank you.
Last slide.
Dr. Amol, Dr. Mahendra, nice presentation.
Yeah.
And I think it's a long time in the debate. We are on the almost same page at the end. So as you clearly mentioned that this is the algorithm which we should follow, that patient should be selected properly. There is the surgery is not a SOC in this scenario. The selection is it should be very careful. So just coming to patient today needs a personalized care. There is no single approach. Current available data shows that multimodal therapy, including combination of surgery or therapy, is an ideal method of treating the many patients. Hence, the optimal sequence needs to be personalized for each patient, disease basis, and the patient performance status. Treatment decisions are best made by the MDT, incorporating specialists who are subsequently experienced in the treating patient, the mRCC, as you can say, specialized center and the experienced one. And the last slide is this time. Optimal time of CN is all matter we debate at present, whether before medical treatment or after. We have both the data before or after medical treatment, but both are indicating the good OS in the both the settings. So at present, I think best it must be decided by the MDT tumor board at present how to manage these patients. Thank you.
So can I add my points into this?
Yeah, sure.
Yeah. So as I've shown that the upfront nephrectomy probably is not, there is no confusion that whether we should do upfront nephrectomy or not. If you see the current data of the ICI trial as well as the future trials that are being planned, that there is more or less clarity that we should start with systemic therapy. Those patients who are responding well, and in those who have local symptoms, there we can consider delayed nephrectomy in selected patients. So as of now, I slightly disagree that upfront nephrectomy is probably out of question, especially if the patient is receiving immune combination based therapy, whether it is poor risk, intermediate risk, or good risk. The delayed can be considered to those patients who are doing well and still has local symptoms and who are fit for surgery. That is my probably a take-home message from this.
Okay, so just a last a patient has a clinical scenario, has a operable renal mass with hematuria for last 1 week, hemoglobin from 10 to 6 now. What to do? Immunotherapy, target therapy, angioplasty, or the nephrectomy, it is easily operable, but having lung mets and the liver mets.
So in such situation, we are looking at the patient is having symptomatic because of the local tumor. We may consider the upfront surgery, but how not in all patients, because we have not all patients with hematuria will have a significant fall in hemoglobin, and probably they may respond also to the immune checkpoint inhibitors. But if the patient is symptomatic, patient is going to anemia, the immune system therapy may take time to act. So in thus selected patients in a good center, one may consider upfront also, but not as a standard of care, not to everybody.
This absolutely, I agree absolutely.
Thank you,
Thank you, Dr.
sir.
Amol.
Thank you, Amol sir. Now I will request mRCC sir to give his expert comments.
So I think like in any debate, a debate is being usually given when there is something which is not very clear. If this would have been a question for a TKI, whether to that question has already been unanswered. So there is no doubt about that question. But in this scenario, if we take the data from the real world setting when the study was done, if we go by that way,